Good afternoon. My name is Michael J Kleiman, and I'm a postdoctoral research fellow in the Department of Neurology's Comprehensive Center for Brain Health. Today, I'd like to discuss neurobehavioral markers, such as gaze, gait, and speech, and how they may be able to identify prodromal dementia far earlier than any currently existing cognitive assessment. Let's begin by examining how we currently define dementia and where we still have room for improvement. In the past few years, we've moved towards a system of classifying Alzheimer's disease based on three distinctions: the presence or absence of either amyloid biomarkers, p-tau biomarkers, or evidence of neurodegeneration. This ATN system enables us to efficiently identify where a patient currently lies along the progression of the disease, based on the status of each component. However, the ease in measuring each component is not equal. The biomarkers amyloid and tau are relatively easier to quantify, as they are based on measurable quantities in blood, CSF, or via PET scans with targeted tracers, with these quantities able to be easily compared to a known baseline. Neurodegeneration can also be identified using t-tau levels in the CSF or via MRI. However, it is difficult to localize the source of the degeneration to solely dementia-related causes, as its presence may have been due to an unrelated comorbidity. As the ATN system defines preclinical Alzheimer's disease in three stages, based on the progressive development of each biomarker, the inclusion of easily administered cognitive assessments for identifying neurodegeneration may be useful for determining whether neurodegeneration is progressive concurrently with the development of both A and T, while minimizing the costs and risks inherent with repeated CSF sampling and neuroimaging. If we are able to identify the inflection point of when neurodegeneration begins to ramp up and cognition becomes affected, then we may be able to more accurately determine at which point therapy should move from the secondary prevention phase to the tertiary phase of disease management. Currently, we are ill-equipped to identify any changes within this region after the inflection point, as current cognitive assessments simply are not sensitive to these small changes in cognition and classify those in this period of decline as cognitively normal. This may be because nearly all current assessments require active, explicit participation. Oftentimes, what is being assessed is the subject's ability to perform a given task that is known to degrade as neurodegeneration progresses. For example, the trail-making task or word recall. But task performance as currently assessed only noticeably degrades past the preclinical stage of dementia, leaving us with a sizable gap prior to the onset of noticeable cognitive decline and an inability to be detected using these methods. Instead of examining explicit participation in a task, we can alternatively measure cognitive features alongside a task. We can refer to this as implicit assessment. For example, during the trail-making task, where subjects are asked to draw lines between one number and the next sequential number, the explicit measurement would be the time taken to complete that given task. But an implicit measurement might be to assess motor functioning by examining how straight the lines they draw are. These tasks can be either directed, where subjects are asked to perform a specific task, or non-directed, where they are not given any specific task at all, and are instead asked to simply engage in whatever is in front of them, such as being shown a short video and asked to simply look at the video as if you were watching television. These types of implicit measurements are sometimes referred to as neurobehavioral or cognitive behavioral measures. Behavior because they are actions, either directed or non-directed in response to a stimulus, and neuro or cognitive, as they are directly affected by either neurological or cognitive processes. This type of behavior can itself be measured in order to identify cognitive impairment. For example, we can assess visual short-term memory, not by measuring if a subject can tell us whether they recall a picture, but by using the novelty preference reflex to determine if they have any non-declarative memory of the image. While these behaviors can be assessed in a qualitative way, such as by identifying degrees of abnormality, their main benefit is their relative ease in being assessed quantitatively, provided specialized equipment is available. These quantitative measures are more sensitive to small changes in cognitive functioning than currently available cognitive tasks. Specifically, the types of behavior we can implicitly assess are gaze, or eye movements, speech behavior, and gait. A great amount of research has examined the varying effects of different dementias on speech and language. There are a number of different ways to assess these effects, including a categorical verbal fluency task, where subjects are asked to recall as many items as possible within a given category, or a narrative recall, where subjects must listen to a story and then repeat back the facts of the narrative. Picture description tasks are also used, in which subjects must describe everything occurring within a scene, such as this one. Similarly to the categorical verbal fluency task, picture description tasks focus on semantic retrieval and memory, which is known to be affected in mild Alzheimer's dementias. However, unlike the categorical recall task, picture description requires patients to take semantic knowledge about a scene and convert that into a verbal description, an action that connects both language production and semantic retrieval and allows us to measure a breadth of information. Language complexity is one such aspect that can be used to identify potential impairment. While simple language is not abnormal on its face, a reversion over time to simpler language may be indicative of the development of cognitive impairment. Pausing, as well as nonverbal utterances such as and also increase significantly as impairment develops. Both the length and frequency of the pauses directly correlate with severity of impairment and are especially salient in early stages of Alzheimer's disease. Again, the simple presence of pauses is not a cause for concern, but their gradual increase over time may be. And of course, the ability to accurately describe the content in a picture degrades as impairment progresses as well. Each image has a particular number of content units, and the percentage of units described is directly correlated with impairment. While altered walking behavior is common with increased age, various abnormalities in one's gait may be directly related to the development of cognitive impairment. Sudden and pronounced gait abnormalities, such as shuffling, can highlight neurodegeneration due to Parkinson's disease or Lewy body dementia. If subjects are prevented from focusing on their stride using a secondary attention-intensive task, we are able to identify small changes in both motor coordination and executive functioning. If a machine learning classifier is used to analyze gait-derived features, we are able to identify impairment status as accurately as the MoCA, but without needing a trained psychometrician to administer testing. Finally, gaze behavior, or how subjects move their eyes while attending to a stimulus, has also been shown to effectively identify various types of dementias and measure the degree of impairment. Some studies identify an impaired ability of an Alzheimer's patient to direct attention towards different aspects of the scene. Without examining eye movements, this type of impairment is invisible to a clinician or researcher. However, it becomes clear when examining scan paths such as this one. You can see in the bottom image that an impaired subject exhibits far more erratic exploratory behavior than a healthy control, as seen in the top image. We are also able to assess visual short-term memory using the novelty preference reflex. Novelty preference is one of the earliest reflexes that we develop, and it involves our tendency to view repeated stimuli as non-important, focusing instead on new, potentially more interesting stimuli. Its ability to measure cognitive impairment is simple. If a patient's ability to remember a stimulus is impaired, they will not prefer to look at a new stimulus because they will believe both of them to be new. If we display two pictures side by side and then show one of them later next to a new picture, the majority of non-impaired subjects will fixate the new stimulus reflexively, while impaired subjects will not. The severity of impairment is quantifiable based on the length of the delay. A shorter delay before novelty preference becomes unobserved correlates to more severe impairment. Likewise, longer delays may be able to identify smaller deficits, allowing us to more efficiently measure changes over time. In Lewy body dementias, saccades, or the quick movements between fixations, are noticeably impaired. While some aspects of the impairment are shared with other dementia etiologies, such as anti-saccade performance, others are unique to LBD and enable its differential diagnosis. One such example is the decreased ability of LBD patients to initiate saccades in uncertain situations. If the task is to look at a dot as soon as it appears, but then the first dot doesn't disappear suddenly, patients with Lewy body dementias will hold their gaze for far longer than both controls and subjects with other dementias before they look towards the correct dot. This may be due to degradation of the basal ganglia and superior colliculus in Lewy body dementias, as these regions also function to initiate saccadic eye movements. Frontotemporal lobar degeneration is also able to be identified using gaze behavior. Research has found that patients with behavioral variant frontotemporal dementia often fail to modulate social gaze behavior, presenting as prolonged staring towards human faces. This tendency can be examined by measuring the amount of time spent looking at a face compared to other stimuli. It has also been shown that FTD patients exhibit deficits in recognizing emotions in the faces of people. This can be measured using simple instructionless tasks, such as here, where subjects are shown 4 faces, followed by an emotion word, and then the 4 faces again. Healthy controls overwhelmingly look at the face with the matching emotion, even given no instructions to do so. However, patients with behavioral variant FTD do not exhibit this behavior and instead attend to all faces equally. Analogs to these neurobehavioral markers are occasionally used today in clinical practice, but typically not for identifying neurodegeneration. Eye movements are used to identify acute brain injury via identifying the presence of nystagmus or deficiencies in smooth pursuit and saccade generation. These types of eye movement abnormalities also present with neurodegeneration, but once they become noticeable without specialized equipment, the dementia has usually progressed such that these methods are no longer necessary. Narrative recall or picture description tasks are used in dementia research studies, but typically not in clinical practice, as they require specialized training to be able to effectively administer and assess the tasks. When they are used, they generally just give the clinician a qualitative view of the patient's overall language deficiencies. And while gait is effective at identifying Lewy body dementias, the majority of clinical use consists of simple motor assessments with a binary rating of normal or abnormal performance. While there are exceptions, of course, the majority of these clinical applications use qualitative assessments of neurobehavioral features. When examining eye movements, physicians often identify whether they are normal or abnormal, but rarely use any quantitative measures such as saccade velocity or fixation duration. Narrative recall or picture description may quantify the number of content units, but any impairment is usually qualified as aphasic or abnormal without regard to the degree of impairment. This can certainly be useful, but qualitative assessment leaves quite a bit on the table concerning the measurement and identification of very early impairment. The main benefit of examining behavior is the ability to measure very small changes in cognition, and only quantitative measurement can identify these changes over time. Of course, it is difficult to measure these markers quantitatively by hand. Thus, if we wish to leverage their ability to identify minute cognitive changes, we need to look to computational solutions. First, we must move towards collecting as detailed information as possible and aim to not leave useful data uncollected. Digital collection of patient behavior enables the use of objective and quantified data, so electronic equipment should be used wherever possible. Eye trackers for studying gaze data are currently prohibitively expensive, but clinical use may not require the high specifications used in research hardware. Some gaze behavior, such as the novelty preference reflex, can even be assessed using a simple webcam. And while other metrics such as saccade velocity and fixation duration cannot be measured using such a low fidelity technique, research is currently examining the range of specs necessary to promote clinical adoption. Gait is often measured using specialized floor mat setups. However, new advancements in computer vision technology enable everyday camera equipment to capture similar metrics just from video information. And while collecting speech information seems like it would be simple, just turn on a microphone and ask the patient to speak, anyone who has tried this may be familiar with how many complications can arise, from distracting background noise to patients speaking too softly or too loudly. Quality hardware and software can address these issues. And as both improve over time, the ability to perform real-time clinical speech analysis moves closer and closer to reality. Of course, once the data is collected, it must be analyzed and transformed into clinically accessible outputs, ideally in an automated manner. With the advent of machine learning and the improvement of computational efficiency and cloud processing, the ability to quickly analyze audiovisual information and produce robust quantitative assessments of neurobehavioral markers is just around the corner, or in some cases has just arrived. Our ability to use these markers is still being investigated, but results are promising, and it is possible that in a few short years, we may be able to not only effectively identify the inflection point where cognition begins to become impaired, but track the progression of that impairment more accurately than ever before.